Everyone, and welcome to the physician-led webinar on managing fluid overload in pediatric patients above 20 kilograms. CHF Solutions is honored to welcome our host for today's call, Dr. David Askenazi, who will discuss the importance of maintaining appropriate fluid balance in critically ill pediatric patients. Before I introduce Dr. Askenazi, a few housekeeping items. First, all participants will be in listen-only mode. Second, we encourage attendees to ask questions as they have them via the chat function at the bottom of your screen. Please send your chat to all panelists. Third and finally, participants of this call are advised that this webinar is being recorded for playback purposes. A recorded version of this webinar will be available at www.chf-solutions.com. Again, our host today is Dr. David Askenazi, who is professor at the University of Alabama at Birmingham and director of the Pediatric and Infant Center for Acute Nephrology, or PECON, at Children's of Alabama. He is a forerunner in pediatric renal support therapy and has authored or co-authored dozens of clinical papers and chapters on managing fluid balance and providing kidney support therapy in pediatric patients. Dr. Askenazi also founded the Neonate and Infant Course for Kidney Support, or NICS, at Children's Hospital of Alabama. He received his medical degree from Texas Medical Branch at Galveston and did his fellowship at Baylor College of Medicine in Houston, Texas. So without further ado, it is my pleasure to introduce Dr. David Askenazi.
Well, thank you all so much for participating in this webinar. I hope that there'll be plenty of questions and answers at the end. It is my pleasure to be talking to you about a topic that I think is very important and very timely in the management of fluid overload in pediatric patients greater than 20 kilos. So welcome and thank you for joining. There's some forward-looking statements that CHF Solution required me to put on the slide. And I do have a few disclosures that I am consultant for Baxter, CHF Solutions, Medtronics, and Bioporto. I received some research support from different folks, and we do have some provisional patents on innovations in kidney support. So the objectives of today's talk are going to first be to discuss the impact of fluid overload on clinical outcomes in children, discuss common disease states that culminate in hypervolemia, and I'll use that synonymously with fluid overload, describe the treatment options when children become fluid overload, and then review the aquapheresis prescription for pediatric patients, which will include the access, anticoagulation, blood flow, ultrafiltration rates, and I'll talk a little bit about how we use the continuous hematocrit sensor to help us know how we're doing with fluid removal. So for those who have followed along, you can see that over the last couple of decades, there's been a huge surge in the number of manuscripts that have the title or have in the abstract have fluid overload, and the reason is because we're recognizing as a community that how we manage fluids can have a really important impact on patients' clinical outcomes, and we've all seen patients who have fluid overload, and it's important to recognize that it's not just that they got pitting edema of their ankle. In fact, pitting edema doesn't really hurt anybody. It's everything else. It's the pulmonary edema that happens. It's the venous congestion that causes the kidney to become swollen and could cause it to not function appropriately. Certainly, people can get cardiac edema as manifested as right-sided heart failure, cerebral edema. The lungs can get wet, as we know. The liver can stop functioning well because of congestion, as can the intestinal system. And so how does it happen? Well, as I think about this, I think that at least one of the following have to happen for someone to get fluid overload. There has to be either systolic dysfunction with a low perfusion to the kidneys, so the kidneys are not sensing that they need to pee very much. Or there could be a diastolic dysfunction, a backup of pressure in the heart. The kidney may be abnormal. There may be glomerulonephritis or acute kidney injury, or some reason the kidney is not able to filter water appropriately. Some patients can have low oncotic pressure, and it causes their intravascular volume to be low, although they can have very high total body water. And some folks can have capillary leak despite having appropriate oncotic pressure because the microvasculature may be damaged for one reason or another, for example, during sepsis. And then finally, certainly if you have a backup of fluid and you have a lot of pressure in the vessels from a backup of fluid, then that pushes everything out to the tissues. And so one of these have to be there because if someone doesn't have any of these, you can give them gallons of water and the kidneys are going to figure out a way to get it out and the heart's going to be able to function correctly. So something has to be happening to cause fluid overload besides just that the clinician is pouring fluid in. And it's important to recognize that not every patient is the same. And so I have had patients where, you know, on rounds, the team says, well, how come this patient got fluid overloaded, whereas others didn't? I did the same thing. I gave them the same, you know, types of fluids. And I think it's because every patient's going to be a little bit different. And if we realize and think about fluid as a drug with a therapeutic window, you can overdose or underdose the patient with fluid. And so this is a slide that was provided by Dr. Ronco several years back that I think kind of shows that very nicely, that if you have a patient who has a normal heart and normal kidneys, they have a very broad therapeutic window of just right. However, if you have someone who has poor heart function or poor kidney function, that window of just right is very narrow. And so we need to think about this fluid overload and fluid delivery, not only in how much fluid we're giving, but how much fluid we're giving in the context of the patient and how much the fluid the patient can handle. So in pediatrics, we see different types of syndromes that are associated with fluid overload. Certainly, if you've worked in the cardiac critical care arena in pediatrics, you've seen many patients who undergo pediatric heart surgery who end up having fluid overload. Nephrologists are very familiar with the fluid overload that happens with nephrotic syndrome, as well as glomerulonephritis. Patients with congestive heart failure from congenital heart disease can have fluid overload. We know that kidney disease could cause a backup of fluids. It's very common in the bone marrow transplant population with microvascular disease and hepatic congestion. We've all seen it in patients with sepsis, and certainly you can get severe burns as a consequence of fluid overload as a consequence of severe burns. I don't have time to go into all of these, but I do want to touch on a couple that are classics, and I think let us gain insight on some of the principles regarding fluid overload. So cardiorenal syndrome has been discussed at great length, and recently in the last decade, there's been kind of the shift to not just calling everything cardiorenal syndrome, but really trying to identify whether there's an acute cardiac issue or a chronic cardiac issue, and whether there's an acute kidney issue or chronic kidney issue, or both. And so you can see here that there's 5 different types of cardiorenal syndrome that you could potentially face, and they each have their own unique physiology that goes into the pathophysiology of the disease. So here's an example of acute cardiorenal syndrome. This is type 1. This is when you have a patient who has an acute heart disease, for example, from a procedure. Maybe they're undergoing cardiac bypass surgery and they develop acute kidney injury. And you can see here that it's a very complex system with issues related to hemodynamics, issues related to medications, sympathetic tone, the renal angiosystem, hormonal factors, and how the endothelium reacts to inflammation that can be caused from acute kidney injury or cardiac disease. Again, this is a very complex system, and what I really want to kind of show you is the impact that fluid has, because fluid overload is directly involved in this feedback loop. And so the more salt and water you retain, the worse the heart can start to function because of overdistension, which causes lower perfusion to the kidney, which the kidney then has trouble getting rid of fluid. And so this feedback loop is driven partly from the fluid overload. In sepsis, there is now pretty clear guidelines in both pediatrics and in adults about how to resuscitate patients. And I'm not going to go through this in great detail, but what I want to emphasize here is that there is a shift towards having people back off on fluid at a given time. So yes, absolutely, we need to resuscitate our septic patients with lots of fluids, but there's a stopping point. And that stopping point, if you look at different studies, is usually about 6 to 10 hours after they present to the emergency department, okay? And so you can look through here, the guidelines, yes, give them a bolus, yes, give them another bolus, but there's a push now towards backing off on fluids and getting them on pressure support sooner than there have been in previous guidelines and algorithms. And so there's now this well-accepted concept that we've been talking about really for a while, but now it's really kind of gained entry into the both the critical care and the pediatric critical care arenas, where there's this 4 phases that people talk about in fluid management. The rescue phase is during the time the patient walks into the ER, for example, and they're hypotensive. And absolutely, if you look at the volume status here, we absolutely want to make them hypervolemic. We want to give them lots of fluids, okay? And it's here where I think things are shifting, because in the past, what would happen is you give people lots of fluids, they go into the ICU, and you keep giving them tons and tons and tons of fluid. And what we're finding is that that's probably not the appropriate management. And so once the patient is no longer in this shocky state where you're having to go up on pressors, where you having to acutely bolus them, once you hit that phase, your goal now is to optimize. And your goal is to keep this fluid status flat for a period of time until the patient can be stabilized, and then you could de-escalate the fluid. And so the mnemonic that people talk about is ROSD or ROSE, ROSE. And so again, the 4 phases of fluid management can get you in trouble if you do things perhaps a little bit too aggressively during the rescue phase. Okay, so maybe one can argue that you shouldn't get all the way up here, and maybe you should keep it a little bit lower. But again, I think it's in this phase that we can really serve our patients and teach our residents and fellows, to really kind of watch this line and really kind of assess and make sure that this does not continue to go upward. Okay, so optimization phase. And then again, it's always important to recognize that not every patient is different. And so asking, what is going on with the patient that's making them fluid overload? Is it one or more of the following things here, I think can help us in managing these patients. So I want to shift now to pediatric specific data. And so these are the number of publications that have been out there over the last couple of decades. And you can see here this really kind of big shift right around 2000, where and after Dr. Goldstein published his seminal paper that I'm going to show you in just a second, and there's just kind of been a big rampant. And I will tell you that it's an area that I think as someone in pediatric critical care, I think I'm proud that pediatric led the field, because historically it's the adult data that we use to kind of then translate into pediatric critical care. Pediatricians really were out there before the adults were on this topic. And the reason is because we understand that medications are dosed in a certain way. And so we dosed fluid in a certain way. We don't just give everybody a liter. We give everybody a certain amount per kilo. We don't look at things or think about things in one size fits all like the adults do. And I think that was a really important piece of getting us to this place. And Dr. Goldstein, used this fluid calculation back almost 2 decades ago, and that really has stayed and it's held true. And so what you do is to calculate percent fluid overload, you figure out how much fluid goes into a person, you subtract how much fluid goes out of the person, and you divide by their admit weight, multiplied times 100. So on a good day, if I weigh 70 kilos, and over a period of time, I get 7 more liters in than I pee out, then essentially I'd 7 over 70, which would account to about 10%. It's something that you could do very simply And we do that in all our patients who are at risk for fluid overload in our hospital now. This is the paper that he wrote in 2001. And what you can see here is that if you looked at fluid overload and at the time of beginning kidney support therapy, you could see that those patients who died had twice the level of fluid overload that those patients that survived. This is a very small sample. There was about 20 patients in each of these groups. But it was the first time that people started to recognize that maybe this is really important. Since that time, there has now been 25 studies in pediatrics, and they all pretty much say the same thing. I'm going to walk you through a couple of them. This is a paper published by Dr. Arakan from Texas Children's Hospital that talked about the peak fluid overload time point. You can see here that most patients develop fluid overload on day 2 or 3 or 4 of the ICU stay. And they, looked at how different aspects of fluid overload were associated with the oxygenation index as a measure of pulmonary edema. And they saw that this correlation really started to pick up at about, between 12 and 15%. Others have looked at fluid overload in different ways. This is a paper that did not look at patients who were on kidney support therapy. These are basically all ICU comers. And you can see that the cumulative fluid overload was worse in those that were non-survivors versus survivors. And down here in the bottom panel, you can see the cumulative fluid balance on the y-axis and the day on the x-axis. And you can see how not only did patients have higher max fluid overload, but those that survived, kept going up and up and up. And those with fluid overload required longer time on ventilation and longer and worse oxygen saturations. There's other papers I could have picked, again, in different populations, whether you want to look at Saluski's work in ECMO or Seguin's work in cardiac surgery or others. The message has been clear and very consistent. There's a paper that was published in pediatric bone marrow transplant patients that basically showed that not only does fluid overload make things worse, but if you reduce fluid overload, there's an improvement in your oxygenation parameters, even in patients with bone marrow transplant who we know have very difficult time reclaiming that fluid once it's already in the tissues due to their severe capillary leak that they sometimes develop. And so here's some of that data. Again, I won't go into great detail for time, but here's some of the oxygenation and ventilation indices, and they show very nicely that they were associated with a reduction in fluid overload over time. So this is a paper that was published by the folks in our pediatric colleagues in UT Southwestern, led by Ray Quigley. They looked at CRRT, a form of renal replacement therapy for fluid removal, and showed that those patients who got started sooner, based on their criteria of urea, as well as some other parameters, included fluid overload, had better outcomes than those that did not survive. Again, suggesting that the timing of initiation is a modifiable decision-making point that we can use to optimize our outcomes in our patients. And then I want to leave you with this paper that was published in 2018 that was led by Sean Bagshaw that really looked at a meta-analysis of all pediatric papers at the time on fluid overload. And what I want to show you is that this systematic review and meta-analysis looked at 3 different meta-analysis and 3 different ways to look at fluid overload, whether you want to look at them as categorical values, greater or less than a certain percentage, or whether you want to look at it as a categorical variable that's stratified, depending on the type of definition that was used, or if you want to use it as a continuous variable. You could see that all these papers, except for maybe this one right here in the middle, that maybe was kind of right in the middle, all these papers kind of lean towards favoring fluid overload. And the cumulative number over here is significantly in favor of less fluid overload, improving clinical outcomes. And so we now know, and I think it would be super hard for anybody to convince me that this is not true. fluid accumulation in critically ill patients is bad. Doesn't mean we can't give them lots of fluid during the first phase, but progressive fluid accumulation is bad. So let's talk about the pediatric studies that show that fluid overload is good. There really isn't any. Even though people have tried, I have yet to see a paper that says that fluid overload helps anybody. So what can we do? So let's talk about some practical considerations that I think have helped our program, and I would ask you to consider in your program to kind of help you and your colleagues think about fluid overload and how to address it. I think the first is, becoming aware of that fluid is a drug. Fluid is something that has to be, the doctor has to order it, the pharmacist has to deliver it to the bedside, the nurse has to check it off on the order sheet, and you have to prescribe it. And there is a concept that you can do this in a way where you're overdosing your patient. And so again, helping people understand that fluid is one of the most common drugs we use in our hospital, I think is an important thing to start with. In patients who are at risk for fluid overload, that list that I told you before, anybody who's getting edematous or has a risk to become edematous, I really think that cumulative fluid overload needs to be trended. It needs to be monitored very closely. It needs to be reported in morning rounds like any other vital sign that we have. Okay, so we in our hospital, we make fluid overload part of our vital signs. And if a patient, if a resident is reporting to me and they say the patient had 5 liters in and 2 liters out, my next question is, well, where does that keep the patient? Because if they were 10% fluid overload yesterday, and today they're 14% fluid overload, it's very different than if the patient, was 16% fluid overload and today they're 12%. And so again, getting that signal of cumulative fluid overload, I think is very important. We also try to speak in terms of fluid overload and its clinical effects. Things like as cumulative fluid has worsened, oxygenation index has also deteriorated. It's important, as I mentioned, to consider the phase of therapy that you're in. And again, looking at these things, this is something that I think all residents and fellows who work in the ICU need to understand this concept. It's very important. And I think, all the major critical care societies have recognized and have bought into this. And certainly there's the Goldilocks rule that you have to, be just right. You can't give too much fluid. You can't give too little fluid, because if you give too little fluid, then they have a potato chip-like process. If you have too much fluid, you become the Michelin Man. So there is this kind of just right rule. And as I mentioned before, different patients have a different therapeutic window for just right. So shifting to different options for a patient that has developed fluid overload. You've done what you can, or maybe you walk in on a patient that has been managed by other service, and you walk in or you get consulted as a nephrologist to take care of a patient that is now, let's say, 15 or 20% fluid overloaded. So what are the things we can do? Well, certainly I would ask you and ask anybody taking care of patients to understand why. Why is this happening? And really maximize the medical management for these things. So if their perfusion is low, well, increase their perfusion. If they have oncotic pressure that's really low, maybe you can kind of help that with some albumin. The second thing you can do is really think about fluid restricting the patient. And I can't stand when a patient is in the 4-2-1 rule in the ICU. I think that that's outdated. The 4-2-1 rule is for a patient coming in for a surgical procedure who's not septic, who doesn't have heart failure, who doesn't have kidney dysfunction, who's not fluid overload. Patients who are fluid overloaded do not need the 4-2-1 rule. And I think that that needs to be outlawed in the ICU personally. So the other thing is that, you can fluid restrict, but are you willing to tolerate lower perfusion, lower to the organs, lower hematocrit? So you're going to withhold blood from them? Are you going to withhold platelets from them? Are you going to withhold nutrition from them? Are you going to withhold medications to, again, keep them fluid restricted? So I think there's a role here, and certainly one of the first things I do, when I see a patient's fluid overload is I ask, well, what kind of fluids are you given, and can you restrict a little bit more? The third thing I think we should be doing and thinking about is diuretics. So we recently looked at, all the drugs that are used in our ICU, and by and large, the most commonly used medication above anything else is Lasix, is furosemide. If you were to look in your ICU, you'd probably see the same thing too. But yet, there's been tons of studies that have looked at the question of, do diuretics help ICU patients? To summarize here, this is a review that was done now probably 5 to 6 years ago, but these 8 non-randomized studies and these 6 well-controlled, well-performed randomized clinical trials showed that a lot of patients in the ICU get diuretics, yet there's been no direct improvement in their clinical outcomes. It does not decrease the likelihood they're going to go on CRRT or require other forms of kidney support therapy. It does not decrease their hospital length of stay or their ICU length of stay. It does not change their mortality outcomes. But I don't want to mislead people and say that we shouldn't use diuretics. We use diuretics, and I think it's fine. And I think that it's important for fluid overload patients to get a dose of diuretics to see what's going on. And so the concept here of the furosemide stress test, I think, has really come to light recently. And what it basically tells you is the following. If you're doing the same thing over and over and expect different results, then you're insane. And that's a quote from Albert Einstein. And I think what that means is, if you give a dose of Lasix and it works, then great. If it helps you achieve your goals, that's wonderful. But not only that, but if you give a dose, if you think about it, in order for Lasix to work, you have to have blood perfusion so that the drug can get there. You have to have filtration and secretion and reabsorption, and you have to have a way to get the urine out so you can't be obstructed. So giving a dose of Lasix and seeing that it works tells you that the system is intact. And so people have started talking about this as a furosemide stress test. And I think we do it all the time, but I think what we don't do very well is we don't assess the situation fast enough. We give a dose of Lasix and say, well, let's see tomorrow how the patient does. And I think what this, some studies that have recently come out tell me is, give a dose of Lasix and come back in 2 hours. 2 hours from now, you're going to know whether the Lasix has worked or not. You don't have to wait until tomorrow morning to find out whether Lasix is a good idea. And if it doesn't work, it tells you a lot about your patient's kidneys. There's something going on that's not allowing them to urinate. And so we really need to resist the temptation to redo the test with a better diuretics. How many of you guys have come into the ICU and someone says, well, we've been given it Q12, let's go to Q8. And then the next day, someone decides to go to Q6. And then the next day, someone decides to use a Lasix drip. And then someone brings up an article that says, well, maybe a Bumex drip is better. And so now you're on day 5 or day 6, and someone comes in and says, well, let's add metolazone to the equation to hope that things get better. Sometimes they do, and maybe it's because the kidneys open up at that time. But resist the temptation to just keep doing this test with a better diuretic. And this is the actual work by Ming Chawla and his colleagues that really kind of solidified that if you give a dose of Lasix to a patient of about 1 to 1.5 mg per kilo, you should expect them to have 200 cc's of urine in the next 2 hours, or they've failed that test. And their likelihood to progress into worsening renal failure has gone on, and they are not likely to pee over the next 2-3 days. And again, that cutoff to develop worsening AKI and oliguria and persistent oliguria, comes with an AUC of 0.87, which is really a pretty accurate test as a measure of what you can predict over the coming days. So again, please avoid the temptation to say, okay, I have a patient that's fluid overload, and then the next day you make a change and it looks like this, and the next day it looks like this, and then all of a sudden you have this giant puffball that you have to deal with. So, which brings up to the next thing, and that is the concept of fluid removal therapy, or aquapheresis, or ultrafiltration. And I use those, really pretty synonymously here. Because, and I certainly don't think that anybody should have fluid removal until at least the concept and things have been thought of about how we maximize medical management. Have we fluid restricted? Have we tried a dose of Lasix? But if you're not achieving your fluid balance goals with those three things, then I think it's appropriate to start to begin this ultrafiltration process. And like all other interventions, we use this when we believe that the natural course of events are more likely to lead to harm in our patients than the likelihood of harm from the intervention. That's how we think about antibiotics. That's how we think about pressors. That's how we think about putting someone on ECMO or on a ventilator. And that's how we need to think about fluid overload. So when do we start ventilator support? We don't wait until the very last breath for someone to go on a ventilator. We work and we think about it as, if things continue to go as I think they're gonna go, and it's gonna make my life harder and my patient's life more difficult, that's when I need to intubate somebody. We don't start nutritional support when the patient is completely starved for many, many days. We don't start cardiac support when the patient's blood pressure is 0 and the heart rate is 0. We start it when the perfusion, when your goals for perfusion go down, when the risks and the benefits and the scale make it such that the potential benefits outweigh the potential risks. And so when should you start fluid removal support? I think it's the same thing. When there's impending harm from the inability to maintain fluid homeostasis affects the physiology. When if you don't do something about this, the patient's going to become more fluid overloaded and is going to be on more ventilator support, or their heart's going to get worse. And so in essence, when your patient will likely benefit from it. And if this was a procedure that had tons of risks, then the benefit risk ratio kind of goes away. And that's where I think some of these new devices, including the CHF solution devices of the Aquadecks, really come into play, because in reality, it's a catheter, you spin blood around and you take fluid off. There's not a lot of risk to this procedure, and I'll talk a little bit about pediatric data that we have that will show that. So if you choose to use a fluid removal procedure, you certainly can put in a PD catheter in. There's kidney renal replacement therapy that comes in not only ability to remove fluid, but also to clean electrolytes and clean waste products. You can certainly do 3-hour hemodialysis session, or you can do aquapheresis, where you're primarily removing ultrafiltration, which is removal of plasma water. And each has advantages and disadvantages, and I'm not here to tell you which one is better, but I will tell you that it's nice to have a toolbox where you can choose one or the other, and your choice is going to be guided by what you think the patient's going to do best with. What are the goals of your therapy? What are the potential risks and benefits of the procedures? What do you have available? How much does it cost? And so those are what's going to drive your choices. And so it's kind of like a toolbox. If I have a nail that I need to drive through a board, I could certainly try to do it with a screwdriver or a paintbrush. But if I have a hammer right there, then I'm going to go pull out the hammer to do the job that I want done. And so I want to talk a little bit about Aquadecks machine. It's a simple concept, and it's for those of you guys who have done any type of extracorporeal therapy, you'll find that this is a really, really simple machine. And it's nice to explain that to families and to some of my colleagues that it's really simple. You have a double lumen catheter. You have this console here that has 2 pumps. One is a blood pump that spins the blood from the patient to the console and then back to the patient. And then you have this filter system that you can put into the machine, and in less than 15 minutes, even if you're not a skilled nurse, even if you're a pediatric nephrologist, you're able to kind of follow the numbers and prompts, and it kind of walks you through the process to really kind of get this up and running. It's really a very simple machine to work with. So the Aquadecks FlexFlow was FDA approved in 2007. There's now a newer version called the SmartFlex. They both have the same filters, which are approximately 35 mils. And as I mentioned, it's a relatively simple, and then has a blood pump here and an ultrafiltration pump here. And here's where the filter goes. So here's some data from our recent study that we published with our friends from Seattle Children's and Cincinnati Children's Hospital. It was a 3-center retrospective chart review on patients that received the any type of therapy with the Aquadecks FlexFlow from January 2012 when we started until March 2018. Some of the other centers started at around 2014, 2016. And the primary outcome was survival to the end of treatment, with secondary outcomes including patient survival, kidney function. And this is also very, descriptive manuscript about, how often did patients have problems going on circuit, what kind of complications did we see, things of that nature. And so I'm going to focus here on pediatric patients that were over 20 kilos. Our manuscript's divided into that cohort, as well as a 10 to 20 kilo cohort, and then a less than 10 kilo cohort. But for the purposes of today's conversation, I'll talk about those greater than 20 kilos. And most of them received the therapy with just ultrafiltration. There was a few that received ultrafiltration with some extra replacement fluid for clearance. 97% of those patients survived to discontinuing kidney support therapy, and 23, or about 68%, survived a hospital discharge. There was no complications at circuit initiation in all these patients who were over 20 kilos. We didn't have to give them a bolus or calcium or bicarb or change the pressors. 2 patients in the group had repeated admissions, and after greater than 12 months, and we treated those a little bit differently in that they were we just had to use some statistics and repeat measures. This is one of our patients. I do have permission to show the slide. She's a patient one of the first patients we did ultrafiltration on, and you can see she was right about 20 kilos at the time. She had glomerulonephritis with nephrotic syndrome, and she was massively fluid overload. She was very resistant to diuretics, and but her kidney function was relatively good. And so we used the Aquadecks machine to, kind of bring her back from, 20-25% fluid overload over a period of about a week down to closer to her dry weight. I also want to mention that we used this same data set to help CHF Solutions apply to the FDA for submission. For this data set, it's a little bit different in that we removed patients who were less than 20 kilos from that initial cohort, and we removed those that were receiving other types of the ones that were receiving replacement fluids. And so it ended up being about 25 patients, and most of these were what we think about as kind of classic ultrafiltration patients. That included bone marrow transplant patients, critically ill patients in the ICU, and patients with cardiac failure. There was a couple of patients who were either on chronic dialysis or acute dialysis, where we used aquapheresis in between the chronic hemodialysis sessions. And our conclusions really, as we listed them, is that number one, aquapheresis is safe and effective in patients weighing greater than 20 kilos who receive continuous ultrafiltration, with 97% surviving to the end of therapy. Although not all lived to hospital discharge, these are patients who were very critically ill with multiple other problems besides having too much water on them. And there was very few complications. Most of what we saw had to do with catheter malfunctions that, that caused our circuit to stop, and we had to put them on a new circuit. We had a few patients that had minor bleeding. We didn't have any major, head bleeds or that we knew of. And then, concluding that Aquadecks can and should be used for pediatric patients who have failed to try diuretics, because we really feel, based on these initial data, that it is a safe and effective therapy. And so shifting to the prescription, I'm going to talk a little bit about detail about how we approach our patients as it relates to access, anticoagulation, blood flow, and fluid removal rates. There are some differences in kind of what we do versus what Cincinnati does and what Seattle does, but not very different. There's a couple of little things that I'll mention here. So for the most part, we could use a 6 French double lumen catheter or larger. Generally speaking, all the catheters that we've used have been 15 centimeters or shorter. We place them in the IJ, or a couple of them received them through antecubital, kind of like a PICC line. We obviously want to be in the right location, which is at the tip of the right atrium, SVC junction. And I mentioned that there is a catheter that can be placed, antecubital that's designed to be just right, about 15 centimeter catheter. There was some patients that received a femoral that either with a high approach or a low approach, low being kind of below the bifurcation, high being above the bifurcation. But this is, pretty standard to any other extracorporeal therapy, except to say that because we need lower blood flows, we can get away with slightly lower size catheters. From an anticoagulation perspective, in our program, what we do is in a heparin naive patient and a patient who's not at risk for bleeding, we would start by giving a 20 units per kilo bolus and then put them on 20 units per kilo per hour with a titration rate to try to get the patient's PTT between 50 to 70. In patients who may have risk of bleeding, we have kind of a tight protocol, which calls for PTTs of 40 to 60s. Other programs have used ACTs in the range of about 180 to 200. And in our program, we give the heparin via the pre-filter pigtail and measure the PTT post-filter. And let's see if I can show you that here. So yeah, so here's the filter. So we give the heparin in what's called the withdrawal line that kind of brings the blood from the patient to the circuit. And then we monitor on the other pigtail in what's called the infusion line. As it relates to blood flow, I like to go fast. And so we crank it up to as high as we think the catheter will let you. Usually with, again, the catheters that we said, you can get up to 40, sometimes 35, sometimes 30 if it's a long 6 French catheter. But you should definitely be getting more than 30 mLs per minute, or you may have a kind of a problem with your catheter. I want to spend a couple of minutes talking about fluid removal rate because I think this is the key and the art to doing this. And so I'll tell you kind of some of the experiences we have and the approaches that we use. First, to let you know that that the ultrafiltration maximum that you could do is dependent on your blood flow. It's designed to keep a filtration fraction, if you know what that term is, under 25%. And so at 40 mils per minute, you can ultrafilter up to 500 mils per hour. The things that I use to consider how to start the ultrafiltration rate is first, how long do I want to do this? If I have a patient who I know is going to be in the ICU for the whole weekend, well, maybe I don't have to go as fast as a patient that is, dying to get home, and I have to just kind of be more aggressive. So how long do you want to do this for? How severely fluid overload is your patient? It's important to recognize, where is the fluid now? If all the fluid is in the tissues and it's not intravascular space, you may have trouble getting some fluid. So that's something to be considering. And I always, especially in patients who I'm going to be very aggressive with, I always have a conversation with a bedside nurse about what we're looking to tell us if we're going too fast. And so having that conversation up front allows you to say, okay, well, we're going to be aggressive, but we know that eventually this aggressiveness is going to be too fast, and we just got to be ready to back off a little bit. And so we choose a starting rate, and then obviously there's monitoring and titration that comes into play, and very good communication between the prescriber and the nurse is really important to assure that there's an understanding of what you're trying to do and how you want the nurse to kind of back off. And again, the things to look for is to decide when you got to back off a little bit is the vital signs and hematocrit monitoring that is provided on the Aquadecks. So I am a pediatric nephrologist that learned how to do hemodialysis with a hematocrit line. And a lot of other programs and a lot of other people did not. And so I don't know how to really pull fluid off people very well without a hematocrit monitoring system. And so I think it's super important and it's very helpful because it's a window into the intravascular space. Okay, so it allows you to understand the changes that are happening within the vessel in such a way that it really kind of can teach you a lot about whether the patient's tolerating the fluid removal appropriately or whether the patient's going to start to have some hemodynamic changes before those hemodynamic changes happen. On the Aquadecks, there's a really interesting and important safety feature that's called the hematocrit limit. And what you can, and I'll show it to you here. So over here in the white box, you can see, over time, there's a minute-to-minute measurement of the hematocrit, and you see this dashed line up there at around 35. That is set by you of where you want the limit to be. And what that's supposed to do, it's there as a safety feature because if someone has too high of ultrafiltration and their hematocrit all of a sudden starts to go up because they're contracting their fluid and they're becoming intravascularly deplete, then if it hits that line, it's going to stop pulling fluid and it's going to allow the patient to reaccumulate fluid before it restarts. So, and the way that I explain this to residents and nurses and my colleagues is like this. There's only two things that can explain that a hematocrit is going up. Think about what you think those are, and what they are is one is you're either giving blood to the patient or that the fluid accumulation into the vasculature is slower than the fluid removal. Okay, so I'm gonna say that again. So many times as you pull fluid, in the tissues, they start to kind of bring that fluid back into the vessels. And so if you're pulling away from if you're ultrafiltrating faster than those tissues are reaccumulating, that fluid is reaccumulating from the tissues into the vessels, okay, then your hematocrit will go up. If you're pulling at a certain rate and your hematocrit is flat, that means that you're pulling at the same rate that the fluid is coming into the tissues. And here's an example of a patient that we had. It's a nice example. I wish they would have called us sooner because we have parameters that says if it hits that white line to call. But what you can see is this patient, we were pulling pretty aggressively. And over time, it started to kind of go up and up and up. And over a period of about 8 hours, went from a hematocrit of about 30 to all the way to 36. And what happened is that as it went up, it hit this line. And so the pump stopped pulling. And you can see if you look closely that it comes down a little bit and then it pulled again, and then it comes down a little bit and pulled again. And so you can see this kind of zigzag pattern because the machine is doing exactly what it's supposed to do, that when it hits that line, it stops pulling fluid until the patient reaccumulates that fluid into the vessels. And then there's only two things to explain a dropping in hematocrit. One is if the patient is bleeding, and two is if the patient's accumulated fluid into the vasculature from tissues, or if you're giving IV fluids, for example, that's faster than the fluid removal rate. So if you have a patient with a steady hematocrit and you give them a normal saline bolus, you can expect the hematocrit to fall. Or if you're accumulating fluid really, really fast, then you may see that as well. And so here's an example of a patient that we saw. I was walking around rounds and I saw this. I immediately called my my ICU colleagues and say, hey, this patient is having a bleed. And lo and behold, we went to surgery that afternoon and had a significant GI bleed that was happening. As far as titration, you should be pulling enough fluid that the clinical symptoms are slowly improving. If your patient is fluid overloaded with very, very high intravascular volume, they're probably hypertensive, and so hopefully you're seeing your hypertension improve. If your you have a patient who's got pulmonary edema. Hopefully you're pulling fast enough that you can see your oxygenation ventilation improve over a period of time. And it's okay to have a slow and steady increase in the hematocrit line. You're kind of actually looking for just a really slow, gentle rise in that hematocrit line. And you should, however, not be pulling so fast that the patient develops, significant tachycardia, poor tissue perfusion, a drop in the mean arterial pressure if that's normal when you start, and you want to be watching for a sharp rise in the hematocrit. And so as we think about fluid, again, it's that Goldilocks rule of not only how much fluid to give, but also how much fluid to take off. It can't be too much, it can't be too little, it's got to be just right. And I think the ways that you could kind of optimize those targets and that the delivery of fluid removal is to first think about what are your goals. How much fluid do you think you can take off this patient over a period of a half a day or 8 hours or a period of 24 hours, depending, what your time is. Again, don't be afraid to monitor, to pick a number and go for it. Monitor it, knowing that you may have to make some adjustments to get it just right. And what's just right in the beginning, 24 hours later, may be way too aggressive once you've already taken a significant amount of fluid off. If your fluid removal rate was too fast, well, sometimes I see folks where someone gets a little tachycardia and they say, okay, stop pulling fluid. I don't think that's the right thing. If you still have a patient who's fluid overload, it may mean that you were just going too fast and your tissues were not bringing that fluid into the vasculature as fast as you were pulling. So in that situation, what we generally would recommend to do is to stop transiently for 30 minutes or so, let things kind of reaccumulate, or you can give a small bolus, and then start at a lower rate, but don't stop completely. General rule of thumb is that if you're pulling off 10% of a patient's weight in a 24-hour period, that's pretty aggressive. Certainly I've done more than that in a patient who's very, maybe on a nicardipine drip, who's very fluid overloaded. I may kind of, say, okay, well, let's give them, a couple of hours of really, aggressive fluid removal, knowing that, in short amount of time, or at some point, that is going to be too fast, and we would have to slowly kind of bring that ultrafiltration rate down. There is a newer feature on the SmartFlow that on the hematocrit sensor that I want to talk about, in that instead of calculating every minute, it actually kind of smooths out the line by calculating a 15-minute average. But you can change that. You can pick, whether you want the 1 minute or 2 minute. And the other feature that's new is this SpO2 monitor that my ICU colleagues are very, very excited about in when we're pulling fluid as a measure of tissue perfusion. So in summary, fluid overload is a common problem that impacts the morbidity and mortality of our pediatric patients. Several clinical scenarios and several different abnormalities and pathophysiologic systems lead to fluid overload. The treatment options for fluid overload include maximization of medical management to reverse the underlying cause, fluid restriction, use of diuretics, but avoid the temptation to tolerate accumulation of fluid overload. Don't make the mistake that you're just kind of trying a new diuretic every day and while you're watching your patient become a Michelin man. And then fluid removal in the form of aquapheresis or other forms of kidney replacement therapy. Aquapheresis, I believe, is a safe and effective therapy in patients who weigh 20 kilos and have fluid overload, and they can complement your toolkit. Not every patient with fluid overload necessarily needs aquapheresis. There's some that are going to be fine with improving medical management and diuretics and some fluid restriction. But I think it's important to have in your toolkit to kind of help you take care of your patients. Again, that benefit-risk ratio for fluid removal, you can get a lot of benefit in the risks. Certainly there's risks of putting catheters, but we do those for many other supportive organ system. But we've showed, and in our experience, it's very, very rare for a patient to not tolerate getting initiated on the therapy. Certainly patients can get, hypotensive and tachycardic if you're pulling too fast, as long as you're keeping close tabs and understanding that at some point you're going to be pulling too fast, that could be mitigated well. And when you think about the prescription, you got to think about the access, the blood flow, anticoagulation, and really this key of how fast you want to remove fluid. I think those are key elements that that you need to understand to adequately prescribe and perform the therapy. So with that, I thank you guys very much for listening, and I'll hand it over to Pete and for a Q&A session.
Great. Thank you so much, Dr. Askenazi. That was absolutely wonderful. We do have some questions in the chat, so I'm just going to go through some of those for you to answer, please. It'll be great. The first question is, how does the system function with a patient who has fluid overload due to a number of causes such as gut and pulmonary edema? Would there be a need to prioritize focuses and treat the most severe first? Or how do you put that together in your decision tree?
Well, I think I think it's really important to understand that, you can't get the fluid right from the lung. And so, you're not putting the catheter in the lung and pulling the fluid out. You're putting it in the vessel. And so what you want to do is you want to pull fluid from the vessel so that now there's a gradient, or there's that the forces have now changed so that the intravascular fluid has dropped, and the tissues, the gut tissues and the chest wall tissues and the lung tissues are going to now have a force to bring them into the intravascular space. I'm not sure I totally understand the question about prioritization. It's because perhaps I'm misunderstanding the question, but it's not like you can say, well, let's get the gut fluid off first and then the lung fluid. It's really just a concept of let's get the fluid out of the vessels and allow those tissue, the extra fluid in the tissues to kind of get back into the vessels so that then you can take them out.
Exactly. And I think that concept of using that cumulative fluid overload as one of the critical vital signs was a great point that you brought up in terms of really thinking about that every time that we look at our patients. So that would probably help maybe mitigate some of those other problems with developing too much fluid overload, sort of that Goldilocks phenomenon. So the next question just talks about, if you could just clarify and explain what the 421.
Oh yeah, I'm so sorry. So the 421 is kind of a real shortcut way for that we were all taught during medical school and residency on how to prescribe fluids in pediatrics. And so it basically says that for the first 10 kilos, you give the patient 4 mils per kilo per hour. And for the next 10 kilos, it's 2 per kilo. And for the next 10 kilos, it's 1 per kilo. So in essence, a 30 kilo patient would get 44 per kilo for the first 10 kilos, which is 40, 2 per kilo for the next 10 kilos, which is 20, and then 1 per kilo for the next 10 kilos, which is 10. So a total of 70 mils an hour. And I think the message that I'm trying to say is that when we think about maintenance fluids, we want to start with, asking, where's the patient currently at? Is the patient, dehydrated, euvolemic, or fluid overloaded? And then we want to ask, well, what is our goals that we want over the next coming time? Because maintenance fluids assumes that you have normal urine output. Okay, so the 421 rule, or how people prescribe maintenance fluids in adults, at 100 mils an hour, it works if your kidneys are working right. But if they're not, if you're having trouble with heart failure, if you're having trouble with renal dysfunction or some of the other things I mentioned, then prescribing that amount of fluid is not appropriate, and you're going to end up becoming more and more fluid overloaded.
Great. So the next question has to do with the diuretic studies. I mean, certainly I think all of us agree that is the #1 drug that we use in our ICUs. And so the question was, were the diuretic studies that you presented done in adults, or were they all on the pediatric population?
Yeah, that was a meta-analysis of pediatric. I'm sorry. That was a meta-analysis of the adult cohort. there has not, to my knowledge, been that type of a review and meta-analysis in pediatrics. Again, I know that there is certainly a lot of people that use diuretics, but if you really jump in and dig out any large outcome studies, to my knowledge, there's not any really clear absolute benefit in just putting everybody on diuretics. Again, if it helps you achieve your goals of getting a patient off the ventilator, and you have a patient who was very fluid overloaded, and you need to be negative a liter every day to get them to where you want to be, and diuretic helps you get there, great. But if you're using a diuretic, hoping that tomorrow is going to be better than today, even though tomorrow it didn't work, then I think we're missing out. And so I think that temptation to keep making small iterative changes to our diuretic doses or types or modes or combinations, I think can be harmful, because you're not really addressing the problem until day 2, 3, 4, 5, and 6. I think that if it's not working, then you could pull out something else from your toolkit that is, in my opinion, not associated with a tremendous amount of risk.
Great. So that leads us where you were talking about using the furosemide stress test to basically define and quantify presence of diuretic resistance.
Correct.
And then are there any other tools, if people aren't familiar with it, don't feel comfortable using the furosemide stress test, any other biomarkers that you use to sort of help with that decision making?
I think it kind of depends on what type of a syndrome and process you have. Certainly, if you have a heart failure, I think it's helpful to trend and track, the BNP, the beta natriuretic peptide, as a surrogate for right atrial pressure. Sometimes that can be helpful. I think, just looking at trends and kind of seeing and trying to anticipate where you're headed. Things like, if I continue to give this much fluid and my patient continues to be this degree of oliguria, well, I can anticipate it's going to be another 2 kilos up by tomorrow. What's that going to do to my ventilation, and what's that going to do to my overall ability to care for the patient? Sometimes, I think it's appropriate to also start fluid removal in a patient who your goal is really just to take off what you're giving, to say, okay, well, I don't want this patient to be worse tomorrow, so I'm going to fluid remove them to keep them even, because I know they're going to need this amount, liter of nutrition, and they have 5 antibiotics. And so I know it's going to be 2.5 liters of antibiotics that this patient's going to get. And they're getting tons of blood products because of their severe anemia or platelets or FFP for coagulation. Sometimes I think it's appropriate to fluid remove so that you don't get worse, so that you can keep your, that optimization during that optimization phase. I think it's okay to start fluid removal to prevent you from having further fluid accumulation. Not necessarily to, your goal may just be to stay even, and you may need, aquapheresis to keep you even for that day.
Okay, great. And sort of along those same lines, if you compare aquapheresis to CVVH, the question is, comparing those, does aquapheresis have a faster renal recovery, since that you have that notion of letting the kidneys do more? So that would have the implication that you just needed fluid removal and not necessarily clearance.
Yeah, I certainly haven't seen any compelling data that suggests that, cleaning uremic toxins is going to make your kidney get better or worse faster. I think that, I think certainly that concept, I think, maybe comes from the pulmonary arena, where we know that a ventilator causes a lot of, barotrauma. And so there's that concept that if you can, that if you're using a ventilator, you're causing some harm. I think certainly you can take too much fluid off, whether you're doing clearance with CVVH or whether you're just doing fluid removal with aquapheresis, I think you can harm your patient by taking too much fluid off. If you make them hypoperfused and they're not, perfusing their kidneys well, then you potentially can cause ischemia. But I think that, as long as you're getting good renal perfusion, I don't think that either aquapheresis or CVVH really, changes the likelihood of renal recovery one way or the other, better or worse. Because remember, we don't fix kidney injury with kidney support therapies. We do the job of the kidney with kidney support therapies. Much like, you don't use a ventilator to fix the lungs. You use a ventilator to kind of to do the job of the lungs.
Great. Those are great analogies. And I love the way that you talked about starting ultrafiltration or renal replacement therapy in the same notion as we think about putting patients on ventilators or using cardiosupportive drugs. I think that that's a really good model for us to think about this. So, COVID-19 is a huge issue across the country. And just, do you have any experience in your institution with patients that are suffering from COVID or from the multi-system inflammatory syndrome that then have AKI, whereby you're using the ultrafiltration? I know we've had some previous webinars dealing in the adult population with regards to the use of aquapheresis in COVID-19, but just would like to hear your thoughts in the pediatric space.
Yeah, so thank you for the question. I mean, we are absolutely learning that very similar to other septic patients with severe inflammatory response syndrome and who are in the pediatric ICU, they commonly develop renal dysfunction and fluid overload. And we're in the process of putting together a multi-center study that describes that. Again, I think it just depends. I mean, I think about, kidney support therapy, in a way that kind of goes something like this. What is my patient doing that is harming them? Or what's my patient's organs not doing that are potentially going to be harmful for them tomorrow and the next day and the next day? And how can I be on top of that? How can I, kind of help the physiology of the patient so that things are going to be better in the long run for not only the patient, but for me too. So how can, so the example of, using, pressors, they're designed so that you don't end up with poor perfusion that's going to cause lactic acidosis, that's going to cause you to then not have enzymes to function in an acidic environment, which then are going to lead to more and more organ failure. Okay, so the goal is good perfusion, and you start when you think that poor perfusion is going to happen or when you're seeing poor perfusion. Okay, as it relates to fluid removal, I think it's the same type of thing. If I think that the patient's worsening fluid overload is leading to more requirement of higher ventilatory pressures, and I think that that ventilator is harming the lungs. Well, if I believe that I can prevent further need for ventilation, perhaps reducing the number of days on ventilation, perhaps reducing the amount of force that you have to kind of push on those lungs to get them to ventilate, then I'm going to help my patient and myself, because it's going to make my life easier to take care of them in the next couple of days, and it's going to help them, be able to maintain the physiology that they need to get better. So I hope I answered that question.
Yeah, that's a great answer. Thank you so much. You've been so generous with your time. I have one more question, then we'll wrap up. For those of you on the line whose questions were not answered, feel free to reach out to us through our website, and we will try to do our best to get you connected. So the last question is, can SVR be used to gauge whether the UFR is too high?
SVR meaning?
I guess the systemic vascular resistance.
Yeah. I guess yeah, I think if you trend it, I guess I'm not familiar with exactly which tool you're using to kind of measure an SVR. I'm happy to field that question through an email.
Okay.
I'm not 100% sure that I'm familiar with that technology.
Okay. I would think my thought would be probably the author of the question perhaps meant through maybe a PA line, looking at SVR through there. But we can certainly follow up as a offline. So,
Sure.
so thank you so much, Pete. Did you want to have any closing remarks?
Yeah, I just want to thank Dr. Askenazi for your excellent presentation and to the audience for their very thoughtful questions. Once again, this webinar will be posted on our website soon, and that address again is www.chf-solutions.com. So thanks again to everyone, and have a great rest of your day.